So thanks. We have too much content and a shortened amount of time. Okay. So Virginia, Lorenzi, and I are or have been co-chairs of the Patient Empowerment Work Group, which was chartered by HL7 a couple of years ago to incorporate the patient perspective in all aspects of HL7's work. I'm retiring as a co-chair. Virginia is continuing. The first project that was approved for us to work on is an IG for how to essentially implement the HIPAA right to corrections using FHIR. And Virginia, what's the stage that we're at right now on that? Is it going to ballot? Okay, good. So Virginia, as many of you know, is a real HL7 veteran on the board, yes? Right? And New York Presbyterian. And I'm a patient guy, a cancer survivor with no modern tech capabilities, just known for advocacy for patient access to medical record and involvement in rethinking healthcare, especially health IT. What we're going to do today is describe the problem. And for those who don't know, here or virtually, it really is a massive issue, no question. And this has incredible implications because the only reason to record data in a computer is so you can read it back later and do something with it. If you don't do that, there's no use for it. And if it's wrong, it's a problem, right? We'll discuss the current correction process, review this IG briefly. Of course, it's online for anyone to review and summarize where we're at. Very briefly, and these slides, versions of these slides are already on the Patient Empowerment Workgroup Confluence page. Regarding the magnitude of the problem, Geisinger, 2014, front page of the Wall Street Journal Health section, 95% of medication lists had mistakes. Now, considering how many analytics are being done and how many research projects are drawing on this information, the prevalence of mistakes really weakens all that work. And a HEMA literature review in 2013 found that 84% of progress notes contained at least one documentation error. There was an average of almost 8 documentation errors per patient. And although this one isn't as robustly characterized, we do know that medical errors are the third leading cause of death in the US, and some proportion of them are caused by things like missing allergies, missing conditions in the chart. In short, there's no question that there's a strong case for action for doing what we can to correct these mistakes. Hey, yes. Display settings. Oh, wait a minute, we're on the wrong, we want to swap.
You're there, good, so.
It's in PowerPoint that you switch monitors, right?
Yeah, you're good now, though. Yep, actually here.
Well, we're still seeing the next slide, though. We should be flipped. How do we fix that in PowerPoint? At the very top?
Brett's coming.
I don't think it's oh, it's not on here.
Right. That's it. We need to swap displays, which is probably.
You know what? I don't want is it right on Hoover?
Can we?
It's right on Hoover.
It's right on there.
Okay. All right. Let's keep rolling. Good. Thank you. Thank you. A relatively new study about open notes in JAMA, tough peer review process, 30,000 patients. What is going on? Ghosts in the machine. 30,000 patients responded to this survey. 20% of them reviewed a note and found a mistake. 40% perceived it as serious. And if you look at the types of errors that were in there, wrong or missing diagnoses, right? Wrong history, wrong medications, wrong test results, wrong patient, and wrong-sidedness. Again, what we want to do is take action on this. My observation as a speaker and attendee at many health conferences is the problem is some people think this is a patient complaint issue, but no clinician can possibly perform to the top of their training if they're given wrong information. Imagine a medical licensing exam where people were given wrong information and they therefore recommended the wrong thing, but they still got marked wrong. Well, so anyway, Interop obviously means proliferation. So now I will skip ahead. I have to make this personal. This is a new slide, never been shown anywhere. I decided to go to my different providers because this is what FHIR will enable now. You connect to all different providers and pull down things and compare them. So I get care at Beth Israel Deaconess in Boston, Dartmouth Hitchcock. Where, get rid of this. Good heavens. All right, Leahy Clinic, OCB, which is part of Mass General, and Nashua, New Hampshire Eye Associates. These are my different prescriptions for various things. And there are just differences across all of them. Now, a natural thing to say is that supposedly my eye doctor doesn't really need to know about my blood pressure medicine and various other things. But the whole point is that if these are disconnects, you just can't have good care going on. And then there's over-the-counter medications. And it turns out also, so this is my list of conditions: dermatological, skin cancer, various eye things going on, long list, and wildly inconsistent between them. So now what do we do? Yes, Virginia, your turn?
Yes.
Okay, good. Thank you.
This is a question to you. How do you get your record corrected? Anyone done it? Who in the room is not from the United States? Just curious. Okay. No one here has tried to correct the record? Brett has. And you've been successful? No. Yes. Anyone have any idea what you would need to do if you wanted to correct your record, if you saw an error, or your loved one had an error in the record? Wherever you live. No idea. Well, you're not alone. This is one patient's story. She's a famous patient advocate. Terrible trouble in correcting her own record. She's actually made a business out of people hire her. So, and she goes and navigates the system to get people's records corrected. I mean, a business around this. So I will tell you how you do it in the United States, how you could possibly do it in the United States. And the other thing I want to point out is this is the experience when people cannot get the record. They try and they try. So what that means is that we hear about clinician burden a lot. I certainly hear about that. I work for a large healthcare institution, but patients have a lot of burden as well. You know, one, it's that you're sick, but then you have to deal with red tape. And there are studies about the administrative burden and that impact on people. So these patients, so Grace is a cancer survivor. So we have someone with cancer who is fighting the administration of the system as well, just for her care. So in the United States, HIPAA, believe it or not, HIPAA requires that patients are able to correct their record, and they provide an amendment process. So the way you could officially get your record corrected, which you might not realize, is you could make a formal amendment request to a healthcare organization in the United States. And this is a legal right. And you know, I know in Europe, they have the right to rectification in GDPR. But you know, I think in many countries, there's a way to do this. But the way we do it in the United States is the way to officially do it is you submit a request, usually to a department called medical records. I know in my organization, you know, medical records has, you know, you can't even find medical records. You know, where is medical records? And it's often maybe a piece of paper. And then the rule says you have 30 days as a healthcare organization to process that request. And you can make a request for an additional 30 days. There's no requirement to communicate with the patient about how it's going. But this all assumes you even know where that amendment request form is. And a lot of times people just don't know. They ask their doctor. And you can ask your doctor, but your doctor may not even be able to get to the place that in the record that needs to be fixed. Or you ask out of the context of the clinical workflow. And the clinicians, they're trying to go from encounter to encounter. So you get no status. You have no idea what's happening. Like Grace said, she kept asking, it was kept continuing to be wrong. And then you fix it, like they fix it in the current encounter, but it's still wrong in other information that's being sent all over the place. The rule also says that when the record is changed, that change is supposed to be communicated with anyone that the organization has communicated that information with before. And while we might do that in a paper way, has that hit the electronic world? And also, if a patient gets an amendment decision that they don't like it was denied, they have a right to a formal disagreement. So they can write a disagreement and send that in. And that disagreement is supposed to be attached to the record and sent to anyone the patient wants it to go to or to places it's already gone. That's just what the law says, just so you know. So, this is often done with paper, mail, fax, and phone calls. People, you go to the privacy officer and you ask them to help you, whatever, or it just doesn't get done. I think most of the time it just doesn't get done because this is a big wall to scale. And then sometimes we'll say, well, patients complain about things, but they're not actually errors. Well, there's plenty of studies done that says when patients get activated, they have better healthcare outcomes. So the conversation is still valuable. So in that open note study that Dave mentioned, the conclusion was that we need a better way for patients to be able to request an amendment to their record. They said developing efficient mechanisms to respond to such reports of errors appears to be important. At a time when patient demand for data is increasing, and in the United States, we've just kind of gone live, and a lot of organizations have made their notes open and have just in general are making more and more information available to patients on portals, but also with FHIR APIs. So they're able to see more and more of their data, which means they can see more and more of those errors. And when you see an error, well, not only could it, there's so many reasons why it could be helpful, like Dave suggested, but it's also quite unempowering and unsettling when you see that the record's wrong and you cannot correct it. Maybe that's my own personal opinion, but I would feel very unempowered. So the conclusion of this very large study was we need a better way to do this. And when the patient empowerment work group was first formed, we had a lot of things we could work on. But as Dave mentioned, this was our first project because the group was pretty loud about this is a real problem. We have errors in our records, we can't get them fixed. So we decided we were going to create a FHIR implementation guide. And this would allow patients or their caregivers to use these FHIR apps, their actual FHIR apps, and within their workflow, the patient workflow, they would be able to request a correction. And it wouldn't be this one-way conversation. They'd request the correction, and then they could know where their correction went. They could know the status as it's being worked on, even if it takes that whole 60 days, they could have an idea. And if some clarifications are needed, like exactly what do you want us to fix? That back and forth communication could also happen right from that FHIR app. And so I help lead this project with Debbie Willis. And so we have an implementation guide. You Google for it, you'll find it. I have links in the back. And I'm going to give you a quick walkthrough of the spec and how we designed it using FHIR. So we have three main scenarios that we've kind of proven out through the spec. The first one is basically a patient asks for the record to be corrected. And the amendment decision is we accept what you've asked for and we are going to correct the record. And included in this scenario, when we tested at Connectathons, we have some of that back and forth communication. We follow it through its different statuses. And then we say, like one of our favorite ones to say is a patient says they don't smoke. And the reason why we pick that is we talk to a whole bunch of different medical records organizations. And that's a very common thing patients get very upset about. I don't smoke. You know, that really messes you up if people think you smoke when you don't, in many ways. And they have a real hard time getting that off their record. So in our scenario, we had it where the patient actually quit smoking. So we wanted to know when exactly did that happen, so we could understand whether the record should be corrected or not, and in which parts of it. So we had back and forth communication. So the one was the request is accepted. The second scenario is the request was denied. And the third scenario actually happens after that correction process. And this is where a request was denied and a patient comes and just kind of starts another process, which is the disagreement process, where they log that formal disagreement that they have a right to do. And this, like I said, this follows the HIPAA process, but this is not a United States focused spec. The problem of wanting to correct records is an international problem. You know, errors exist in records. We've found many studies across the world that there are errors in records. We don't want it to be US specific. And actually our first live implementation of this spec is in the Netherlands. We have two actors involved. We have the correction requester. Maybe it's a patient on a patient app, maybe it's their caregiver. And then we have the request fulfiller. And we often think of this as probably a healthcare provider using maybe an EHR, could possibly be an HIE or a payer. Trying to be more abstract with these two roles. And then in FHIR, you know, we looked at resources that seem to be, you know, appropriate for this. And the two key resources we use is the task resource, because the task resource is a really great way to monitor a process and track status. And the communication resource, because we felt this was a really good way to do formal correspondence between patients and providers, as well as that back and forth, you know, when did you quit smoking? And this kind of shows the dialogue back and forth using the RESTful API. It's a pretty, we start with the client requester would request a correction. And then that would, the fulfiller would actually spawn, would save that communication, which is the formal request, but it would spawn a task that it would, that task is the way it's going to expose the status to the client. And then the client from that point on can query that task at any point at once and know the current state. You know, is it in queue, being triage, wherever it is in this process, all the way through to completion. But also the fulfiller could decide to maybe ask a question, a clarification question, or the requester could have a question, you know, hey, I've got more information for you, or when did you quit smoking? And that would happen either by the requester posting a communication resource or the fulfiller just adding a communication resource to its server that can be queried by the requester. And then the requester is just going to continue to poll for statuses on task, as well as any new communication resource that's been posted by the fulfiller. In a kind of a more high-tech solution, we'd be using the subscription paradigm. But this will work. And then this will continue until the request has, you know, been accepted and fulfilled or denied, whatever that amendment decision has happened. And status is really important. So the task resource has two status fields. It has task.status and task.business status. And through a combination of both of those, you get the different statuses that we've come up with. And this actually took us, if any of you guys have done work on developing value sets, things take longer than you might think, right? It took us quite a bit to get this. And this has been approved by our, we have sort of an expert panel of patient advocates and medical records professionals, as well as our techies, where we've come up with this is, we think this is the right set of statuses that represent both the request for correction process, as well as that log disagreement process. And then in our design, if you kind of look behind the scenes, we go under the covers, you'll see like a graph of communication resources that represent the conversation, as well as a single task for each process. So the request for correction process, and perhaps the disagreement process, if that's needed, would be a different task. But that single task, the history of it's really important, because at each step of the way, it could be a different status change. And this just shows something that happened at our Connectathon. I don't know if you guys know David Hay. I love David Hay. Well, he created a reference server for this. And so this is a little snippet from his reference server. So you can play with our he both has a client and a server on here. And you see, oh, here is a correction process in flight. It actually is the provider has decided, or fulfiller has decided, they're accepting this request of the patient, of the requester, but they haven't yet actually completed it. So that's the current status, and it actually hasn't been changed on the EHR system, on the medical record. And then you can see some history in the communication back and forth. So you asked me about project status. So this is where we are. I might have made up for time by talking fast. So kick this off in the summer of 2020. That's when we really got going on the work. We have had 4 Connectathons. So quite a lot of kicking the tires on this. But I'm going to tell you, in those 4 Connectathons, there were some key stakeholders that were not at the table, sort of. We didn't have EHR vendors writing code for servers, which we really wanted. We did have several EHR vendors that have been actively involved, coming to every part of the meetings at the Connectathons, coming to regular weekly calls. I see Jeff in the room. Jeff has been very actively involved. I see Isaac here from Epic, and Basile from Epic has been very actively involved in this work. And we have Jason from Meditech has been on weekly calls, really helped us figure this out. But no one wrote code. We had to have David Hay write that code. And we had several of these patient app vendors that have stood up clients, as well as some other people. And then we have one production implementation in the Netherlands, and nothing tests things like production, right? So they have a regulation they're trying to meet for this. Both the Netherlands and Brazil have regulations in place that they need to do this in an electronic way. And they started with kind of part of the spec, and they just started with just lob a communication resource across the river. And what they found from that is it wasn't enough, and they really wanted that status tracking. So they see the importance of the task as well. But they were doing what they needed to do to meet the reg to start. I've been there. I get that. So that was interesting. And one thing they've done is they have a whole bunch of issues that they've logged that based on their actual experience trying to implement this. We went to ballot. Because the community, including, our EHR stakeholders said, you need to go to ballot. You're ready. 4 Connectathons, go to ballot. We passed, yay. But we have numerous issues. We have 27 issues attached to the ballots. And while the Netherlands did not get their ballot in the appropriate format by HL7 process, they have 17 other issues, which we clearly care about since they tested it in production. And from a future direction, we are looking for the fulfillers of these requests to actually store in their systems these amendment decisions and these disagreements, and expose them using FHIR so that we can do that communication of decisions and disagreements between everyone who needs to know, as well as allowing a patient to request it. As well as we want to see the spec implemented so it can meet its purpose. So this is how you can get involved. We have a draft spec. Here's the project information, all of our agenda minutes, etc. And we have weekly calls Mondays at 4 Eastern. If you really want to be involved and that time doesn't work, talk to us. We'd love to make it work and build up that community. We need people to review the spec. We need you to tell us, does this work for you? We really need people to test it. And we really need implementers. So, and we're going to open it up for questions. But in summary, we described the problem of errors in medical records, discussed the current correction process that exists today, and why is that happening? Do you see it over there on Zoom? Okay. Can I move it? No. So we discussed and we reviewed the major parts of the FHIR IG for patient requests for corrections. And we summarized the current status, like where we're going and how you can get involved. So now I'm going to open it up for questions. Really appreciate that you came in the room here. Thank you.
Thank you, Virginia. There is a question online. Are medical errors the third leading cause of death for people who are in a hospital already or for the overall population in general?
The original study looked at, I think it was the top 10 causes of death overall in the population, and medical errors were not listed there, but the number of deaths from medical errors would have made it number 3 in that list. There are lots of articles on that general subject if somebody wants to Google.
Thank you. Any questions from here?
Hi.
You coming to help me?
How do you see this being integrated with existing systems out there? Would this be like a separate app that only does corrections, or should it be like if you already have a patient portal, should it be part of that patient portal as part of the display process?
So I'll talk about me personally outside of HL7 world. I think all patient portals should support this. But from a standards perspective, we need to be able to have anyone who uses the FHIR API, those PHRs, personal health records, should have that ability. So a patient using a PHR can have it right from their workflow.
Yeah, can I add something to that?
Yeah, and I wish I could. I don't know what to do with this. Oh, okay.
So the general idea here is that patients and other people are going to be able to see data that they could never see before. And when somebody sees a mistake, we want them to be able to poke it figuratively or literally and say, fix this. And all we're doing is once the user has interacted with some system and the system wants to send the correction request, we've defined how to do that using FHIR. It's going to be one thing at one of our, was it at a Connectathon or another presentation where we had a vendor speak who has made some correction management.
Yeah, so there's a vendor, maybe it's Compliance Pro, and they help people with other HIPAA compliance things. So he has his own piece of software that certain hospitals are using outside of EHR. So it doesn't have to be an EHR that has this workflow process for, let's say, the medical records people. But it is one of those things that it's a nice thing to have integrated within an EHR. And I don't think that all EHRs have this or have it for patients, whatever. We were looking to have a FHIR IG, and I think we kind of exposed a problem in general.
Yeah, and I think the big ecosystem point here that calls to me, because again, I don't have a background in health IT, but in other industries, once you have a flood of stuff that becomes available, then there's a market for people to develop apps to manage the resolution of all these things. So this is like big time business potential. And considering all the worries that we hear from HIM departments about what they'll do with this flood of stuff, I would think that they would welcome a way to make it manageable, make the load manageable.
And at my organization, we've noticed an uptick in requests for corrections because people are getting their notes. And working with some of my, provider friends across the industry, they've noticed upticks as well. But the more easier we make it for someone to correct their records, I would expect more,
One more question? Yeah.
Hi, are there different levels of permissions for certain correction requests? Like, are there some corrections that maybe the patient can initiate and are automatically approved? Maybe like simple demographic stuff, for example, and then maybe there's some that it only needs an administrator to approve, or maybe the primary care physician, or maybe only a specialist can approve. Are there different levels of permissions?
Yes. Okay, we'll move on. But no, absolutely, you're correct. So there are things that someone could.
Not in our IT.
Well, yeah, but yes. So you're correct. So it could be something where there are things that this is something a patient really owns, like they know. Like, for example, a patient really knows, let's say, their race. Like they know that, whatever. There are such things that you definitely own that. And you know your address. You should know where you live, right? And so that's a kind of a patient initiated. When those requests, first thing is anything could come in as this request because there's a human in this queue that we're trying to feed. And some of those they may be able to fix directly. And some of those they might need to go to doctors. But you could also have a situation where in other parts of our FHIR API, and I see, like Brett in the back, like we've been trying to do FHIR right for ages. There is the idea that maybe there is something that could be automatically updated. Sometimes portals will provide, you can just put the address in and that will accept that. But always you're going to have people that will still want to fill out that form and put in a request of some kind.
But I can't stress too strongly. We had a bunch of arguments early in this project about, I don't want patients going in and writing into the EHR or anything like that. We very carefully, the scope of this thing is how do you send a request to somebody else using FHIR instead of paper?
Yeah.
And what happens at the other end is none of our business. And I, as pro-patient as I am, I pointed out that during the worst of the pandemic, there were idiot patients in South Dakota in ICUs denying they had COVID right up until the time they died of it in the ICU. And so you don't just want to assume patients know everything. So
the idea of this idea is to put something on that queue for that manual. Maybe it'll be semi-manual. Maybe there'll be something where part of it's automated. That's fine. That's up to the innovation over there. But a patient, and you said we send it over there, but that's not all. You also get to track status. You're not like with Grace, where she said, I ask and I ask, I never hear back. And only thing I see is the error is still there. So now you can see what the status is. And you can also have this back and forth conversation where needed for clarification. Was another question?
There was another hand back there.
Question? Another question? Anyone?
I guess he withdrew the request.
I don't see any more questions
There even.
online. Okay,
they're still
you
there.
do have some questions.
Sort of a comment and question, I guess, but this looks like this could be expanded to other areas beyond what you've put in here. We work for a payer, and I could see a process like this being used, say, on a appeal, or, we're dealing more with things like address updates, phone number changes, and this whole process flow that you have laid out could be used for any type of update process. So have you thought about expanding the use cases?
There are two paradigms here. That one is the request process, right? So one example would be a release of information process. The same kind of people in my organization do that, but you could track status. So that's one part, is that whole thing where I can track status on a request. The other side, which my co-lead Debbie Willis is really big on, is just being able to do back and forth communication, but from FHIR. Just kind of like what I have on a portal where I can do communication. How can I do that conversation? So we did some work in terms of tracking conversation in all of our connectathons.
I have what may be a final suggestion. I was honestly a bit surprised to see more hands didn't go up when we asked if you've ever tried to get mistake fixed in your chart. It is likely that there are mistakes in your chart, and it will do you good personally to go find out, go to all your doctors, look at all your stuff and find the mistakes. Some of the serious problems that have been reported to result is if there is a missing allergy. Now, my wife, when she had her first child, before I knew her, almost died because a penicillin allergy was missing from the chart, and they tried to give her some. My mother, who's 92, has a new eye doctor, and then during the intake process, an idiot clerk in the front office took her medication list, and because she was on gabapentin, the clerk took it on herself to write into the chart that my mother was diabetic, which she wasn't, all right? And the thing is, in the 12 years I've been looking at chart errors, what I've discovered is there is nothing in the process that ensures that mistakes don't get into your medical record. And I can tell you the time to check into it is before there's a crisis. So, I mean, I had a radiology report that somehow identified, there was a chest x-ray, identified me as a 53-year-old woman. I wasn't going to end up with any medical consequences from that, but there are other ones that are more serious.
You could find an error in your record that looks like, oh, this is wrong. You know, that's the lab result doesn't look like I have this. I don't think I'm positive, but whatever it is, you know, and it could turn out that it's someone else's result and your record is intermingled with someone else. I mean, it could be a very serious problem worth looking at. There's another study that I didn't quote on here, which is there was a study done on who gets their records, who actually successfully gets their records corrected. And the study showed that the demographic that gets their records actually corrected, that has the highest chance, is white women of a certain age group. So there's an equity issue here as well, you know.
Thank you so much, Dave and Virginia. We are out of time here. Excellent discussion, excellent presentation. Thanks everyone for joining us today. And have a wonderful rest of the day and enjoy the rest of DevDays